I'll be speaking about the cost and the funding, but I really got the short end of the stick today, thanks to Jason, because there's really nothing to say. It's been the same for 6 years, and I will show you that now. And if you have seen these slides, it is you're not dreaming. It is the same slides that we've been using, because nothing has changed. So it is so very important that we engage with these figures to understand where government is at and where we have to start talking when we start presenting alternative models, engaging around funding, possibilities, these kind of things. So I'll touch on the estimates that we have at the moment in the white paper and so on, and the shortfall and required growth to meet those funding requirements. Some of the fiscal implications, just very briefly then, and economic considerations. Also, this new white paper, the one thing, Johan highlighted a couple of things, but now for the first time they're saying they have a preferred scenario B, which I'll just show to you and look at briefly before then concluding. So hopefully I'll be very short and won't keep you too long, and I know the numbers and the figures often bore people, so please stop me, but let's see. Okay, so the white paper estimates that we have at the moment, they are not based on any technical work from Treasury. We have been waiting for the Treasury paper from Treasury Department of Financing. Apparently that exists. Some people may have seen it. We can't say anything about that. What we have now is what is in the white paper at the moment. So this is from the Department of Health, and it is the same as we have had in the green paper from 6 years ago, 2011. It is still the same 2010 figures, and I'll say something about that now, which I quote here as illustrative projections and do not represent the actual expenditure commitments that will occur. So again, I may be wasting people's time because it is not representing what the government thinks that we'll be spending, but this is the only thing we have to engage on at the moment. The exact service delivery model is still unknown. There's definitely more detail now than what we've had previously, but as Johan also pointed out, still some building blocks that are outstanding. A lot of the detail, the costing of the package and so forth, we haven't seen that. And then the funding mechanism, as we know, will also have an effect on what we can collect and therefore what we can fund. So all of these things are interlinked and are unknown at the moment. We really were disheartened, I think that's the word, when we saw the new white paper with the 2010 figures in it. We had thought that at least it would have been inflated, if not with healthcare inflation, then maybe just with CPI up to 2017. I really think maybe even a first-year economics student or junior analyst at Treasury in the Health Department can just have inflated the figures so that we can be moved back into reality. But we don't. We have the same figures. So here you have them from the green paper, the white paper in 2017, 15, and in 2017. In 2015, they told us that these are the adapted figures. They were shuffled around there, but this is the adaptation that we're sitting with from August 2011 when we first saw these. Within the shortfall, the white paper still works with this 72 billion shortfall, or year I suppose we should say, based on the 3.5% growth, which we all know is highly unlikely. Very interesting, this quote that's in both of the white papers as well, that says, it's not useful to focus on getting the exact number because you'll end up tied to endless cycles of revision and efforts to dream up new revenue sources, thus focusing on issues that have more to do with tax policy than health policy. The question of what the NHI will cost is the wrong approach. This precedes the chapter, this is the introduction, the second paragraph of the introduction, to the funding of the biggest government expenditure item that we will see, unless the nuclear deal gets through. But this is the biggest thing that our government is committed to at this moment, where efforts focused on legislation, working groups is going to, and we're wasting our time thinking of revenue sources. So here we hope to have done them some favor by inflating the cost to 2017, just using CPI. This is all the same figures. They look unfamiliar because they are in 2017 terms. So that 370 billion is the 256, 55 that we've seen all day and that are in both of the papers. So what we have here, these are the cost estimates, the light blue line, that's the cost estimate according to the white paper. This is actual government expenditure, public health expenditure, and then the medium term, well, this was actually actual budget forecast. So those estimates are based on a 6.7% annual growth in the public health budget. But we are now, so far off that we actually need a 12.3% compound annual growth rate annually just to get to that estimate. This is the size by which the health budget, health expenditure, public health expenditure needs to increase annually. So this is amidst fiscal pressures on education, many other, pension side. We want our health minister to negotiate for or put a budget forward that increases by 12% annually over the next couple of years to reach this expenditure target, which we in any case think may be insufficient. So the shortfall that we're working with, we actually looked at, this is the white paper one of 108 billion if we use the 2% growth scenario, which is a very optimistic scenario. In 2017 terms, that's about 156 billion that we need annually. Every single year from 2025 onwards, if we assume that their assumptions for the costing is correct, we will need that annually. So as you can see there, that we have to fund 4 soccer World Cups every single year, and we are still recovering from 2010, the construction mess and everything that we have to deal with there, or building 1.4 million RDP houses. That's not the correct term anymore, but every single year, that is what we can do with that money, and that is what we need to fund the NHI. This is a very old quote from Bank of America in 2011, saying that assuming an equal split between corporates and individuals, each sector would have to pay 5% more tax on average, in our view. This will lead to an increased labor cost for South Africa on top of already existing income pressures, and this will reduce government's ability to ensure job creation. And this is again on top of minimum wage and other pressures that we also see. So just looking at that shortfall, the 156 billion in 2010 terms, we just show the shortfall as a percentage of each type of tax revenue in the latest budget. So those are your different, your 3 biggest income sources for government. And it means that we basically need 3/4 of corporate tax income to go straight to, so this is not their plan, this is just a illustration to give you some idea of what the size is of the numbers that we're looking at, or 14% of total tax revenue that we need in addition to fund this policy. Again, just looking at that shortfall, the 156 billion in 2017 terms by 2025 as a percentage of government expenditure. And basically it means a doubling of the health budget. So what we have at the moment, if it grows by 12.3% annually, we need to double the health budget by that time to fund this plan. I think this is the point here, is that we're trying to fund a very specific plan here that's put forth in the white paper at the moment. Now, there are some problems with getting more taxes, as I'm sure most of us would be aware of. And the first of these is that South Africa's tax to GDP ratio is sitting around 30%. I saw the latest IMF document said 29, 30%, the one that Charles Simpkins also commented on. And where our counterparts, sub-Saharan Africa, even upper middle income countries, which were classified as, according to the World Bank classifications, are sitting at half of that. So scope for increasing taxes on a very limited tax base, I think is minimal. Being very optimistic, it would be minimal. So we need to take into account where we are now. So there was this nice paragraph that was inserted in the white paper saying growth in 2016 was at 0.6%, and we take note of this. And someone wrote that paragraph that was very nice. It had no impact on the rest of that chapter. They proceeded with the 3.5% growth rate assumptions, while noting that we are not in a great state of growth in the economy. So it is really a difficult environment to start increasing your tax burden. We know that our previous Minister of Finance said they're trying to get about 28 billion extra this year, really struggling to do so. I mean, now we want to get 156 every year from 2025 onwards. And it sounds far in the future. It really isn't. For those of you and those of us that have been here for 7 or 8 years with this policy, it's, 2025 is not too far off that we're trying to implement these things. So you all know we're at low GDP growth rates, rising government debt, and then this high tax to GDP growth ratio. So when one starts looking at increasing taxes, there are a couple of things that you need to consider, and they actually note some of these in the white paper. So the impact on equality that you need to look at, the relationship between investment and tax rates. Very importantly, we looked at research that said that public expenditure actually has a bigger effect on reducing inequality. So increasing government grants, which I guess is a hot potato by itself, but that actually has a better redistributive effect than taxing the rich or the wealthy more. But you don't reduce inequalities by taxing more. You reduce it by public expenditure, whether you do that via facilities or grants, or the point is that just taxing more is not having the effect that you want necessarily. Then earmarking, so that means ring fencing, the money that you collect only for NHI, is also a very interesting topic that we actually have written notes on it. You can have a look at it. You can do a lot of research on what the possibilities are. But there are pros and cons of earmarking. So it often results in a mismatch where your revenue stream is constrained and you actually need more money, but you can't because of it, being ring-fenced to one specific source. And then the opposite as well, when it protects you against any type of adjustment or funding that may be needed in other government areas of expenditure, but then being heaped up in one area where it's not being used efficiently. So there are options to structure this as a benefit tax if you really want to do those kind of things, or then the insurance type of scheme, which is sort of what's being proposed by Paul Harris and Julia. So. Okay, just briefly then this preferred scenario B, which they talk about in the white paper, is a payroll tax of 2% and a surcharge on taxable income. So the surcharge, that's your personal income tax, so the different rates that everyone is paying in the different income bands, all of that just increases with 2%. And the payroll tax is like like you would pay your PAYE now. It's just a flat rate 2% then. So it basically comes down to the same thing. It has a bit of a different effect on employers and labor depending on how you structure this. But it comes down to what Johan also said, a 4% tax on income, or the cost of labor if you want to look at it that way. So we ran quite a complicated big CGE model. It's called the Dynamic Computable General Equilibrium Model. There's about 5 or 6 of these in the country where you actually model the entire economy. Okay, it's very often used in academics. It has great use for policy making and having to see the results of policy effects. So we ran this scenario through a CGE model, which is calibrated to the South African economy. So the model, the baseline scenario, takes into account current forecasts over the long term as well, and the structure of the current economy that we have. So Stats SA actually publishes the tables that one needs for this, that gives you the structure of the economy, and then you can start doing your own elasticities and so forth. Okay, so then we run this and we we use this shortfall. This just looks different because of using our own GDP growth forecasts, IMF, World Bank, and so forth. And this is the white paper shortfall that they're trying to fund. And interestingly, which I think is a great thing for our model, is that it comes very close to one, because Treasury has a similar model as well, which it actually comes close to what they are trying to fund, but this is not enough. We just saw that getting 70 billion is not enough, and it definitely doesn't come close to what we think the shortfall will be. But this is the amount of additional revenue that you can collect. We actually ran the model twice. You specify different closure rules for the model. So in the health scenario, and there's a balanced budget. In the health scenario, you say all of the additional money that's being collected is being earmarked and spent in health. So you collect all the money in the model, you run it all through the Department of Health. And then there are different direct, indirect, multiplier, follow-on effects that dictate what the final collection in revenue is towards government. Because it's all obviously dynamic and interactive. And then the balanced budget just says everything we collect, we distribute equally as is the current ratios. So it's distributed across government. Usually has a better effect because more departments and sectors benefit from the money being reinvested or spent in the economy from government side. But that's, I think for those who are more interested, I can explain more of that. But the point is we still don't think it's enough to fund this. The chances of it being earmarked amidst political pressure to fund other government items are, we think, not realistic or feasible. So what will be spent will probably be, or what will go to health and NHI will be a lot less than what we see here. So then, I mean, there are so many concerns that one can highlight, and I think the previous two speakers also did a great job of that. But like we said now, I mean, the funding model is still uncertain and it's very limited for fiscal substitution, taking money from other government departments, or then increasing taxes. I think we're at the limit of both of those. The 10% of taxpayers makes it difficult, even if you have people contributing to VAT across the spectrum. That's very little, so your tax base effectively is still very small. I have a couple of slides that we can go through if you want, but the supply side constraints, Johan has also mentioned that, you know, in terms of hospital beds, doctors, clinics, nurses, community health workers, which we'll need thousands of if we're trying to do this model, all of that is constrained at the moment and would need a lot of lead time before we start implementing. On the demand side, we actually expect some of our earlier work looked at what we can expect as an increase in demand. So as you can imagine and figure out for yourselves, many of the other countries that have implemented these kind of insurance models see a very big spike in demand. It's called insurance-induced demand, because where I used to pay for what I need to access, I can now access it free. So even for me, that don't have insurance for primary health care, I now wait another 2 days and see if this ear problem ache will go away. But if it's free, why would I wait if I can have free care and see the nurse or the pharmacist or whoever for free? So it's a known phenomenon that we have insurance-induced demand. The other part of that is pent-up demand, especially in the public sector, where you have people that already are demanding healthcare but cannot access it, whether that is physical barriers or financial barriers or whatever the case may be. We have a lot of pent-up demand. And then this severe quadruple burden of disease that we have in South Africa, which I also think people are familiar with. So in the initial green paper estimates, so everything we looked at now, the cost that we're looking at now, they actually took into account many of these things. About 60-70% increase in demand, which is modeled on the Thailand system and what they saw there after introducing universal health coverage. But we are arguing that that is not sufficient. We think that if we have proper primary health care, even at a community health level or nursing level, the diagnosis of diseases will be so big, things that were previously undiagnosed, people living with chronic diseases and so forth in many of the rural areas that are not diagnosed at the moment, will be so big that we'll really have a very big spike in the beginning. We do believe that will be in the short term. I think once you start delivering effective care, getting those on treatment, you will save on everyone that went straight to hospital because they never got effective primary care. So we just think the cost estimate should take these kind of fluctuations into account, that you have an initial, whether that is 3 to 5 or 10 years spike in costs due to effective service delivery, but then hopefully a reduction later on as the population health is better managed, assuming obviously effective delivery and quality care. So then there are all these other building blocks, and we have written notes on all of these things, the accreditation and quality assurance, which Johan actually spent some time on, the Office of Healthcare Standards. So there are a number of serious problems in terms of that. Payment and contracting methods, he also touched on. We're struggling to get capitation right. There are some successes with ARMs in the private sector, but the kind of data on individuals that one needs to effectively implement a capitation model is not something that's currently being collected in South Africa. So perhaps in some pockets in the private sector, but now you want to do this across the population. So the DRGs, all of that, I think there's so much that can be learned from the private sector's efforts in this regard, because these are all the right terminology and the right way to go, but one can learn so much from what have been done and tried in the private sector and work from that. This referral system, we've talked about some of the problems in that regard. Service delivery model, human resource requirements, we have also looked at that a lot. One can only actually determine this once you know what the service delivery model looks like in detail. Will there be 5 community health workers with 1 nurse overseeing them, and this is the number of people looking, those are the kind of things that one needs to assess when you look at the HR requirements. And if it's a primary care heavy model, as it should be, we need to start training these people. You need to start training the nurses and community health workers, and there are some efforts in this regard. It's not nothing. But we need a lot of work. And then, of course, the task shifting, scope of practice implications. There are so many aspects that one needs to consider when moving forward. So, again, I think as everyone has said, we need overall health reform and universal access. But whether this plan is the best way to achieve that, we don't think this is the best option. So then, just in conclusion, I think I haven't touched on the political, and I'll leave that to the political economist, which I'm not, but clearly we've all seen that the political economy is currently dictating the way that things are going. So this is also something we need to take into account when thinking about the way forward. Neil will spend his time talking on the regulatory challenges and all the implications there. And then we have this... on the side, depending on which forum you're in, either a very big and very important HMI going on, or something that's going on the sidelines that we're all investing money in. But the HMI, the Healthcare Market Inquiry, is supposed to look at many of these problems, actually in public and private, and they've heard from the public side. So we're also expecting solutions to especially the private sector's problems, from that perspective, and how these things are interlinked and taken into account. One can but wonder if the efforts and the money being spent on that side is being put to good use when designing a policy of overall healthcare reform in the country. I think I'll leave it at that. I'll keep my Eden slides hidden for now. Thank you.
Yeah, thank you very